Hi guys, welcome back. The next topic that I'll explain to you is disorders related to the platelets. One of the first questions that is asked on this topic from the clinical perspective is that what is the threshold below which would you be giving platelet transfusion to a patient? You see, the normal platelet count would be oscillating between 1.5 to 4.5 lakhs. But if a MCQ is mentioning a hematological malignancy, let me say if he gives you a scenario of acute myeloid leukemia, or for that matter of fact, myelodysplastic syndrome where you can have at least two or more cytopenias present, please remember in case the platelet count in these hematological patients is less than 5,000, then you would be starting platelet transfusion, which could either be platelet rich plasma or single donor platelets depending on the availability. But if in a multiple choice question he mentions the presence of concomitant fever or is giving you a scenario of dengue hemorrhagic fever and is saying that the platelet count of the patient is reducing, and at this juncture even the patient would be nervous, relatives would be relatively nervous as well, because they'll be asking you, his platelet count is falling daily, so when are you gonna decide? So platelet count less than 10k is an indication for right away giving platelet transfusion to a patient. This is actually a main carry home message from this discussion, because after all we study about disorders which would be having bleeding, but we should be knowing what is the threshold below which we are going to act. Now, if platelet counts continue to fall, then there would be varied manifestations developing in a patient. One of them is going to be petechiae, which due to gravity will initially appear around the ankles and may be missed by the patient, because you see nobody would look down and look at his ankles and see these beads. But as they progress and come upwards, that is when a patient will definitely come to you with either a visible petechiae, or he might just say that I'm having some bleeding spots present on the skin. You see, petechiae per se would look like mosquito bites, but when you press on a mosquito bite, it will blanch on pressure, whereas petechiae are characteristically non-palpable and are also non-blanching in character. I mean, however hard you press on them, this color of the petechiae is not going to change. In contrast, when you talk about purpura, it is a palpable bleed in the skin. Though I will be discussing a surprising MCQ with you that says non-palpable purpura. Why I'm saying shocking is because when I say it's a palpable purpura and then I discuss MCQ non-palpable, I mean the first query that I get right on this lecture would be that, sir, you said it is palpable, then how could it be non-palpable? The logic is if a purpura is small, it could be non-palpable as well. I have also shown in this case purpuras in the oral cavity of this particular individual. He's a case of ITP. I'll be discussing about both the acute and the chronic versions of idiopathic thrombocytopenic purpura, which is immunogenically mediated. But I just want to highlight at this particular point of time that these spots which are seen reddish in the hard palate of this patient would be a wet purpura developing in this chap. Well, whenever there's going to be a problem with clotting factors, in those circumstances, we always will be having joint bleeding. But when it comes to platelet disorders per se, it's mainly petechiae, purpuras, wet purpura, and then obviously there could be life-threatening bleeds occurring in the patient as well. The standard presentation that I've just highlighted can range from petechiae to purpura, but never a joint bleeding. That's the main message that I want to convey, because I'll be discussing initially mainly platelet disorders, acute ITP, chronic ITP, then I'll talk about Bernard-Soulier and Glanzmann thrombasthenia, and in all of these I'll be describing the various types of bleeds that are anticipated. The message is, whenever a patient is having deficiency of clotting factor number 8 or 9, or let me say 11, you see I'm also describing hemophilia. You see that will also be covered in this discussion, but I'm just giving you a brief overview here that okay, let's put this, because I think you know this. Can you tell me what is parahemophilia, guys? Hemophilia A is deficiency of factor 8, hemophilia B is deficiency of factor 9, Christmas disease. C is gonna be 11, deficiency. The question is still open. I think you have read about hematology even from pathology. So can you tell me clotting factor deficiency, which one per se is what you read as parahemophilia? Well, your answer would be factor 5 deficiency. So some questions that I'm discussing with you at the moment are very baseline, are very straightforward, but yes, they are definitely important. Then comes the core issue that I've just highlighted and sensitize you to it, non-palpable purpura. You see, if the purpuras are small, there's a possibility they may not be felt. The answer for this would be given as acute idiopathic thrombocytopenic purpura. It's immunogenically mediated, but when it comes to an alternative MCQ that says pinch purpura, you see, if I pinch my skin hard, I'm not having any bleed. It might maybe cause a bruise if I pinch really, really hard, but as such, not a visible reddish bleed will appear immediately. But in condition by the name of cutaneous amyloidosis, the skin blood vessels will become fragile. The wall of the blood vessel is fragile. So that's why minimal trauma can contribute to a bleed, and therefore we call it pinch purpura. The third question that I want you to remember is that traditionally we always read purpuras with decreased platelet counts. But this MCQ will say non-thrombocytopenic purpura is seen in. The topic that I am going to give the answer here has been discussed even in relevant sections of vasculitis and rheumatology. Well, you guessed it right, Henoch-Schönlein purpura. So these are some manifestations very particularly asked in the exam. I definitely want to highlight the fact that whenever it's going to be hemophilia occurring in a patient, then the usual presentation is going to be hemarthrosis. Most clotting factor deficiencies will begin with joint bleeding, which may be bilaterally symmetrical as well. So the child will not be able to walk, and because they're congenital, so that's why it will mainly be having a pediatric presentation. Two more extra facts before we proceed further. Which clotting factor, because we're talking about hemophiliac aspect, so I said which clotting factor will be having the shortest half-life and which will be having the longest half-life. The therapeutic importance is that the one that is having the shortest half-life, the moment its values will fall, the prothrombin time, I've given you a hint also, prothrombin time will dramatically increase. Well, the clotting factor with the shortest half-life happens to be factor 7, which explains that why in chronic liver disease, prothrombin time is always elevated. Whichever index of the liver that I've discussed with you, whether it's MELD score, whether it is Nazar's index, discriminant score, in all liver parameters, prothrombin time / international normalized ratio is always deranged. Why? Because factor 7 is shortest half-life, the hepatocytes are damaged, the synthesis will be hit, and therefore prothrombin time will start jacking up or increasing. In contrast, if he mentions which clotting factor will be having the longest half-life, then it would be factor 13, that is also called as the clot stabilizing factor. I have dedicated this slide rather to some very baseline paraphernalia that you should be familiar with, so that I can now focus on the core issues, and the topic that I'll explain to you now would be called as acute ITP. Well, one thing is very clear, because it is immune mediated. If you're gonna give platelets to this individual, if platelet count is falling, it's a waste of resources, because the antibodies in this guy are gonna be waiting for the platelets to come in. The moment you give platelets, the antibodies are gonna hit on those platelets, and therefore the end result would be that it would be a waste of resources. All those platelets will be destroyed. It's like slaughter of all the platelets that you are given. So what are the viruses which are incriminated in pathogenesis of acute ITP? It could be Epstein-Barr virus, which causes kissing disease, then cytomegalovirus and rubella. So yeah, there's definitely a antibody-mediated response after viral infections, and that can cause cross-reaction with antigens on the platelets as well, causing mayhem, and therefore bleed manifestations will occur in the patient. Most of the time in the question, he might even write the terms primary versus secondary. So primary is always going to be answered by you as immune mediated. When it comes to secondary, then I would highlight that it could be associated with myelodysplastic syndrome, where we have cytopenia, so platelets can definitely be affected, or autoimmune disorders like systemic lupus erythematosus. In fact, in SLE I've highlighted the type of anemia seen in SLE is of two varieties. No, one is anemia of chronic disease, second is autoimmune hemolytic anemia, and even an autoimmune thrombocytopenia can occur in patients of SLE. Apart from this, even HIV has been associated. Now you can definitely argue that why HIV was not included in the first one and included in the second one. So that's a slight discrepancy that is noticed in the book, that the viruses are mainly mentioned in the primary variety, but one that is included in the secondary happens to be HIV. Coming to the clinical features of this particular disease, the first and the foremost would be presentation of nosebleeds. You see, initially, India when there's a nosebleed, people think that it's too hot outside, because we are predominantly a very hot country. So people think, that the bleeding from the nose is related to the heat exposure of an individual. That definitely can occur. When you go out in extreme hot environment, they could be drying of the nasal mucosa, and then there could be a bleed. But in this case, it's going to be recurrent nosebleeds occurring in a patient to the level that he has gone to a ENT chap. Maybe the ENT chap did some packing also. But because the bleeding is going to persist, therefore the ENT doctor told the patient that go and see a physician. In a female patient, there might be menorrhagia occurring. Now, this might look very non-specific initially, and that is the usual reason why lots of time patients might present to you relatively late. But once a person starts noticing these petechiae, you see, they initially appear around the ankles, so they might still not be noticed by the patient, but as they go up, then definitely they will be noticed. And if you're going to take the BP of this guy, then when you inflate the BP cuff right up to 200 millimeters of mercury and deflate it, even below the BP cuff, you might be seeing this petechiae. Or let me say, if you have admitted this guy in the hospital because he's sick, then when you put or perform ECG, then the suction cups that are used during performance of the ECG could also be having below them the petechiae once you remove the suction cups. In the later part of the illness, purpuras will appear, and as I highlighted, in this particular disease, they may also be non-palpable. This is not a hard and a fast rule. When the purpuras will become bigger, that is when they will definitely become palpable. Please remember the fact that usually spleen is not found enlarged in this condition. So I would just like to highlight this fact that the size of the spleen in most of the cases would be normal, though it may be rarely, very rarely, that says that textbook categorically mentions that spleen tip may be palpable. The word is may be palpable. Otherwise, in majority of cases, the splenic size would be normal. So I'm gonna do a quick workup of this particular person. I know that I'm dealing with thrombocytopenia. When I did a complete blood count, the platelet count is gonna be definitely lesser. So I have asked my hematopathologist to actually focus on the peripheral smear as well. The report coming from the lab will say that even in a peripheral smear, in a cell counter, obviously we can see that the automated system will tell us there's a thrombocytopenia, but even in a peripheral smear, there would be scanty platelets and the size may be relatively bigger. Now, I will talk about a condition before you later, that is having giant platelets, that is Bernard-Soulier disease. But here the word is not giant, it is large platelet. The word giant is used because sometimes platelets in Bernard-Soulier can be so big that they might be as big as a white blood cell. So in Bernard-Soulier, you will notice me saying that there is a pseudo elevation of the total leukocyte count of the patient because platelets are so big that the computer, the Coulter will basically Coulter is a computerized system that does cell counting. It uses a laser beam to measure the size of the various cells. Now the platelets are as big as a white blood cell. There could be a false elevation of TLC in Bernard-Soulier, but the word is giant there, and here the word is large platelets. As I've highlighted, platelet count in these patients can dramatically be low to alarming levels that the patient as well as relatives are asking you that when would you give platelet transfusion? You will not give platelet transfusion in this person because it's like I would say slaughter of the platelets. You give them, and the bad news is that the antibodies are waiting to destroy it. So we will talk about strategies that can be used to actually bypass the immunological attack in this case. I can also do a bone marrow aspiration in these patients. Lots of time bone marrow aspiration will be normal, or in some cases the pathologist just might casually just write clinically correlate. I mean, most of the time you see the reports that come from pathology department just say please correlate clinically. But there's a possibility that if it's an experienced pathologist, he might just mention regarding the size of the megakaryocytes being also relatively bigger and the count of the megakaryocytes also being relatively more. This is compensatory change, right? Because the platelets are being killed outside. There's a slaughter mayhem happening outside in the bloodstream. So the bone marrow is trying to compensate for the damage that is occurring, and that is why the megakaryocyte size and count might be increased, though this finding may not be appreciated if you are having a young budding pathologist. I mean, it requires experience to actually visualize the slides. You see, most of the time the work in pathology nowadays is done by computers only. I mean, we have all the technology available where we can pick up the types of cells using flow cytometry. So the work of a pathologist is becoming relatively, I would say, more towards artificial intelligence. And here I can just highlight the fact that acute ITP will usually be having a presentation that can be easily picked up and can be differentiated from dengue hemorrhagic fever, which is so common in our country because there would be no mention of any fever. And then even the recurrence of these manifestations, the recurrent bleed manifestations, can definitely give you a hint towards that the probable diagnosis of the patient is not an infective cause of thrombocytopenia, but is rather immunogenic process. Coming to the treatment of this condition, we will be starting the patient on intravenous steroids, which will mostly be methylprednisolone epsilon, and then two more strategies which are to be deployed are dependent on whether the person is Rh positive or Rh negative. You see, I shall be giving RhoGAM to this individual. Now, traditionally, you read about RhoGAM or Rh immunoglobulin with respect to Rh incompatibility, but why am I using it here is because this is going to distract the harmful antibodies. How? The mechanism of action of giving RhoGAM is that it causes saturation of the Fc receptors. You are aware from your basic sciences that Fc receptors are going to be the ones with help of which the antibody will bind on to the platelet. In this case, all you are doing is literally distracting the platelets. What you are doing basically is that you are inhibiting the Fc receptor function, and therefore the platelets are very much there, but they're not going to be able to act on the platelets and cause a destructive effect. The point is the enemy is still there, but you're neutralizing the capability of the enemy to harm you. In contrast, when it's going to be Rh negative patient, for these patients we will be giving intravenous immunoglobulins. Now the query of most of the students is that okay, in Rh positive case you distracted the antibodies. Why intravenous immunoglobulins now? Then intravenous immunoglobulins are antibodies against antibodies. So what they will do is that they will help in enhancing the clearance of these harmful antibodies. Mark my words there. The harmful antibodies which are attacking the platelets, they have to be removed from the circulation. So depending upon Rh positive and a negative scenario, we can be using IVIG or RhoGAM for these patients, and the mainstay of treatment would anyway be IV steroids. Now, like all autoimmune processes, these patients might be having a waxing and a waning course and can progress into chronic ITP. If he says what is the mainstay of treatment for chronic ITP, it would be elective splenectomy. Though I mean it's easy for we doctors to say ki operation karwa lo. A lot of patients may not be very comfortable going in for surgery right away. If he agrees for elective splenectomy, you have also to take care of the fact that he could be susceptible to development of capsulated infections. So therefore, I would like to give vaccines to these patients. The vaccines that would be given and have been discussed earlier are Hib vaccine for Haemophilus influenzae. Then is the pneumococcal vaccine, because anyway pneumococcal sepsis can occur in these patients. And then would be meningococcal vaccine. Actually 4 vaccines are given in these patients. There's going to be 3 against the bacteria and 1 against the virus, that is the influenza virus. And conditions where I have taught you elective splenectomy over and above chronic ITP is hereditary spherocytosis. But unfortunately, if there is a relapse after a splenectomy, that's definitely possible. I mean, the immune system is definitely reacting in spite of the fact that you have tried to remove the spleen from the body of this patient. Or if a person is having contraindication for splenectomy, which could be ranging from maybe a comorbid condition presenting in this patient, like this guy is having maybe triple vessel disease, or he's having uncontrolled diabetes. So whatever be the scenario where the person is not undergoing a splenectomy, that is where we can be using drugs. Now these drugs, you can definitely revise them from the pharmacological domain, and they will definitely help you to increase the platelet count. One of them is romiplostim, the second one is L-Thrombopag. Well, the name itself will tell you, no? Thrombocytes word is used to L-Thrombopag, and then romiplostim definitely are gonna help you in increasing the platelet count of these patients, but they're backups, they're not a primary approach that would be used for management of a patient of chronic ITP. I shall now be comparing the manifestations of ITP with hemophilia A, which is gonna be one of the common disorders where bleeding manifestations can occur. I want to highlight the fact that the most common disorder contributing to bleeding, or most common bleeding disorder, is not hemophilia, it is actually von Willebrand disease. In this particular case, factor VIII deficiency is the main reason why he will bleed. The pattern of inheritance is X-linked recessive, which tells you the fact that the disease will mainly be presenting in boys, and girls are gonna be carriers. How's this boy gonna present? The early presentation can be like, let me say this boy is a Jew and he underwent a circumcision. So whenever you read excessive bleeding with respect to post-circumcision, you see this boy underwent a circumcision procedure, and excessive bleeding post-circumcision should alert you. I'm not saying it is confirmatory, but it should alert you to the fact that there could be some bleeding disorder present in the child. As this child will grow up, he will start crawling, creeping, and then standing with and without support. So you would have seen children falling also. Every time the child will fall on his knees, or maybe his ankle will get slightly twisted, because children, when they fall, you see they fall in all directions. So obviously there could be injury to the big joints. So most of the time, the presentation that is going to be answered as the most common presentation of hemophilia is bilateral hemarthrosis. So he has multiple times in the exam given an image of an infant, and I'm not saying that it's always going to be bilateral, because suppose he fell on his left side, right? So the left side took the impact primarily. So if the weight of the body will mainly fall on the left, so there's a possibility that the left side bleeding might be more than that of the right side, or it might be asymmetrical as well. So don't be under impression it's always going to be bilateral. That depends on the side he will fall, right? That side that definitely takes the hit is the one where the hemarthrosis will be more prominent. So it can be asymmetrical hemarthrosis, it could be unilateral, it could be bilateral. Yes. And that is when a mother will definitely notice that now the child is not moving his limb at all. You see, a playful child always loves to play, and he's silent, he's crying, and he's not able to walk. A mother is worried. That is when, in the retrospective history, she will tell you, the doctor, I've noticed that every time he has a little bit of injury, also, I have noticed a bruise appearing on the skin of the child. So, easy bruisability. And then she might say that my brother also had a similar complaint, or my brother had expired. So whenever you read, and this positive family history thing may not be always elicitable, depending on the education level, I would say, and obviously the families are so far apart that people don't bother to, talk about the family history component. So mainly I want you to focus on excessive circumcision bleed, easy bruisability, bilateral hemarthrosis. The genetic hint may not be given in the question also deliberately, because then it will make the diagnosis easy for you. I also want to tell you that suppose this child has not been diagnosed and the child is playing in the stairs with his sister. And like children, they keep on having fights. So the elder sister, she just pushed this boy and he fell down the whole flight of stairs. Now children fall down the entire flight of stairs, nothing happens to them. They just cry for 5 minutes, they're fine. But this kid, if he falls on his head, entire flight of stairs, there could even be a possibility of intracranial hemorrhage, and therefore raised ICP posturing could also be manifestations, and the child will actually die because of brain hemorrhage manifestations. Let's look at what are the tests that I can order for this child. Let's talk about the screening test and then the confirmatory test. The screening test that I will do in this case would be a coagulogram. I will be checking for bleeding time, prothrombin time, and activated partial thromboplastin time in this child. You see, bleeding time is dependent mainly on the platelet function. Prothrombin time is mainly dependent on the extrinsic, E for England, extrinsic system of clotting, that is activity of 5 and 7, and the APTT is mainly related to factor 8 and others. The bottom line is that in this condition, bleeding time will be normal, prothrombin time can be normal, but APTT will definitely be deranged. Just for the sake of completion, I can mention the normal values, though I know you know them from pathology. 2 to 9 minutes, 11 to 16 seconds, and 30 to 45 seconds. So when I see this report, I definitely am concerned about this child, and I would like to run some specific tests to be sure. If he says what is the best test for diagnosis of hemophilia, A, B, or C, your answer would be factor 8, factor 9, factor 11 levels. So in this particular case, it is factor 8 levels that would be checked, and the values might be down to even less than 1% of what is present in a normal child. In these circumstances, I will be telling the parents that we will be giving your child on a regular basis a product made by DNA recombinant technology. When they ask you what is the treatment of choice for hemophilia, a lot of guys casually start answering fresh frozen plasma, cryoprecipitate, prothrombin complex concentrate. Guys, I'm not gonna wait for this guy to bleed and then treat him. I will prevent the bleed. How will I prevent the bleed? I can give this kid a product made by DNA recombinant technology, that is factor 8 concentrate, which will have to be given on regular basis. So the parents will be told that you need to come to our hemat clinic on a regular basis, and we'll be giving this concentrate to the child on a regular basis so that it does not bleed. Now, like in COVID-19, there was a lockdown, traveling was not possible. The child might be in rural India and he might have to be brought to your tertiary care hospital. So lots of time transportation issues can be there. So let us assume that during the lockdown period, that is March, April per se, this child could not get factor 8 concentrate in 2020. As a result of it, the values of factor 8 will again fall back in the body of this child, and now there's a possibility that the same child was playing with his sister, and maybe the fight occurred between the two siblings, and the elder brother or sister hit the child and he got a cut on his lip. You see, if a normal person will get a cut on his lip within a few minutes, or maybe with application of ice, the bleeding will stop. But in this particular case, if he specifies that the child who was playing with his sibling got injured and there's a mucosal bleeding, then what are you gonna do? Because local measures will fail in this case. You would be using desmopressin, you would be using, either it will be written desmopressin or it will be written DDAVP in the MCQ. That is the decision of the examiner, whichever way in pharmacology he wants to write it. But do remember that if he says life-threatening bleed, you see, the same kid was playing in the stairs. The brother who's elder to him or sister who's elder to him pushed him down the stairs. I did not say brother primarily because if it's an elder brother, even he could be having hemophilia, no? So that is why I'm saying sister, not that I'm saying that sisters are gonna beat up the brothers. What I'm trying to say here is that it's an elder sister who's not suffering from the disease and the younger brother is. And if there's a life-threatening bleed, then we would be giving fresh frozen plasma. Yes, we can also give cryoprecipitate in this case, as the pathologist would have told you. But I would like to highlight that in Harrison it is written that with cryoprecipitate, the risk of infection is relatively higher. You see, fresh frozen plasma is stored at -70. There are no cellular components, so chances of infection is very less. Whereas with cryoprecipitate, the infection risk is relatively more. So in Harrison is written a line in this topic that cryoprecipitate is used only in developing countries in emergency scenario of management of life-threatening bleed in a case of hemophilia. Otherwise, you can use fresh frozen plasma. And as I highlighted, situations like these should never arise. If you are gonna be explaining to the mother in a correct fashion that what is the urgency of coming to the hospital on a regular basis to get these shots of factor VIII concentrate, then definitely she'll buy what you are saying and the child would not have to endure all this trauma per se. And most of the time, the question that has been asked in the exam is just an image based where they will show an infant 0 to 1 year of age. Usually the child will be having either the bleed in the knee or maybe the bleed in the ankle joint. That depends on the kind of injury that he has sustained, and you would be able to pick it up, the diagnosis, on the basis of the tests that I've highlighted. Next, I want you to be familiar with certain very peculiar terms that are used in multiple choice questions. Like one of the questions that was asked in the exam simply said, what is autosomal hemophilia? Well, you will answer, this is von Willebrand disease type 2N. I will be speaking about von Willebrand disease towards the end of this particular video lecture, but I just want you to remember the term at the moment. Hemophilia A is pretty straightforward, but he asked autosomal hemophilia, that would be the commonest bleeding disorder. I reiterate my statement, the commonest bleeding disorder is not hemophilia or its subtypes, it is von Willebrand disease. I've already sensitized you to the next MCQ, parahemophilia. That is going to be deficiency of factor V. The third term, when it came in the exam the first time, it stumped a lot of people. It ruffled a lot of feathers in a sense that the term written in the MCQ was acquired hemophilia. And the usual query of a lot of doctors was that, see, we have read hemophilia is congenital, it is genetic, it is X-linked recessive, and the examiner is trying to take some kind of, is trying to take out his anger on us by asking us acquired hemophilia. Well, as the name suggests, acquired hemophilia, the problem in this case is that there is antibodies against factor VIII, and therefore there is a faster clearance of factor VIII from the body. I want to highlight the antibodies related to factor VIII are contributing to enhanced clearance of this clotting factor from the body. Now the question comes, why would this be happening in any individual? Well, your first answer will be this could be autoimmunity. Second could be malignancy. Now that's very interesting when I say cancers could be contributing to acquired hemophilia. So we need to know which are those cancers which can contribute like this. Then two of them, one of them happens to be one of the commonest cancers found in men on a global basis, carcinoma prostate. And second, in lymphomas, especially non-Hodgkin's lymphomas, you could be having antibodies acting against self factor VIII, causing enhanced clearance, resulting in this development of acquired hemophilia. Clinically speaking, the bleeding will obviously occur in all of the disorders that I'll discuss in this lecture, but it has usually been seen incidence-wise that it would mostly be in the form of soft tissue bleeds, more as compared to joint bleeding. As I highlighted earlier also, joint bleeding is a very classical feature that you see with hemophilia, which is genetically acquired, but here it would be soft tissue bleeding, which is more as compared to joint bleeding. So obviously both can occur, but then incidence wise information has been mentioned before you. To detect these antibodies, they do a very particular test that is called as Bethesda. You see, the term itself, sometimes will help you cause difficulty in spelling it out, that is Bethesda assay, helps you knowing about the titers of the antibodies. What these antibodies are doing is actually two things. One, they might actually be inhibiting the function of factor VIII, and second, they might be causing an enhanced clearance also. So this antibody against factor VIII can actually have a multi-pronged effect. Now, if bleeding occurs, what are we gonna do? We are not gonna give factor VIII in this case, because if you give it, the antibody can cause two things. Either it will not allow it to act, or it might cause an enhanced clearance. In either of the two scenarios, if you give factor VIII, it's not going to be useful, it's going to be waste of resources. So just like in acute ITP, I was saying if you give platelets to the person, it would be a waste of resources. Similarly here, I want to tell you that if you give factor VIII, then it's going to be waste of resources. So what are we going to give? We're going to give PCC for these patients. PCC would stand for prothrombin complex concentrates. And when I'm writing it, I hope you would have recalled from central nervous system discussion, I have explained the fact that if a person is on long-term warfarin and there's a warfarin toxicity developing in a chap with intracranial hemorrhage, then I will not wait for fresh frozen plasma to thaw, because fresh frozen plasma is frozen. It will take half an hour, 1 hour for it to thaw, and then you can give it to the patient, and half an hour, 1 hour, the CNS bleed will increase. So in warfarin toxicity with raised ICP, we tend to give prothrombin complex concentrate, which is a ready-made source of clotting factors. And the second indication for prothrombin complex concentrate is what we've discussed at the moment, that is acquired hemophilia. So these terms are to be remembered. I am now going to explain to you regarding two disorders. One will be having large platelets, that is Bernard-Soulier, and the small platelet one, that is called as Wiskott-Aldrich syndrome. So let's take them up one by one. I'll first explain to you what is the fundamental defect in this condition. I mean, why is it that the patient will come to you? And most of the time, the clinical presentation in the MCQ will begin by saying excessive post-operative bleeding. It could be post-appendectomy, it could be post-dental extraction. Any minor surgical procedure is ultimately going to result in excessive bleeding in these patients, which is not going to be controlled by local hemostatic measures, and that is when the case would be referred to the medicine department for an evaluation. The pattern of inheritance of this condition is autosomal recessive, so lots of time history of consanguineous marriages might also be given in the question. Well, the name of the receptor, you can remember for Bernard-Soulier begins with B. Here the receptor is also having this nomenclature, that is 1B, and the main function of this is that it's going to bind to the tissue glue. Well, what is the tissue glue? That is von Willebrand factor. Von Willebrand factor is produced by the endothelial cells which are lining the blood vessel which has been injured, and the end result is that the binding of von Willebrand factor to 1B is what you refer to as platelet adhesion. But in this condition, due to genetic reasons, this platelet adhesion is defective, and therefore the clot is not able to form, which results in increased incidence of post-operative bleeding in these patients. There are two primary aspects which are asked in the exam for this particular topic. One is what I just highlighted even in the starting and right now also, that is giant platelets, which might be misread by the Coulter device as a white blood cell, and therefore a pseudo elevation of TLC can be present in this condition. And second, the problem in this patient would be that of adhesion. The next topics that I'll explain to you will be having giant platelets, that is Bernard-Soulier, and Wiskott-Aldrich, that is having small platelets. So let's take them up one by one. I'll first explain to you what is the fundamental defect in this condition. I mean, why is it that the patient will come to you? And most of the time, the clinical presentation in the MCQ will begin by saying excessive post-operative bleeding. It could be post-appendectomy, it could be post-dental extraction. Any minor surgical procedure is ultimately going to result in excessive bleeding in these patients, which is not going to be controlled by local hemostatic measures, and that is when the case would be referred to the medicine department for an evaluation. The pattern of inheritance of this condition is autosomal recessive, so lots of time history of consanguineous marriages might also be given in the question. Well, the name of the receptor, you can remember for Bernard-Soulier begins with B. Here the receptor is also having this nomenclature, that is 1B, and the main function of this is that it's going to bind to the tissue glue. Well, what is the tissue glue? That is von Willebrand factor. Von Willebrand factor is produced by the endothelial cells which are lining the blood vessel which has been injured, and the end result is that the binding of von Willebrand factor to 1B is what you refer to as platelet adhesion. But in this condition, due to genetic reasons, this platelet adhesion is defective, and therefore the clot is not able to form, which results in increased incidence of post-operative bleeding in these patients. There are two primary aspects which are asked in the exam for this particular topic. One is what I just highlighted even in the starting and right now also, that is giant platelets, which might be misread by the Coulter device as a white blood cell, and therefore a pseudo elevation of TLC can be present in this condition. And second, the problem in this patient would be that of adhesion. The next topics that I'll explain to you will be having giant platelets, that is Bernard-Soulier, and Wiskott-Aldrich, that is having small platelets. So let's take them up one by one. The usual clinical presentation given in the topic that I'll explain to you now will be excessive post-operative bleeding in a patient. It could be like this guy underwent an appendectomy, a young chap, right? And post-operatively there's an excessive bleeding, or I can say he underwent something as simple as a dental extraction. The local hemostatic measures have been taken, but still the bleed is occurring. And this might have occurred even earlier also, when the parents are saying that when he was a child and he had some kind of injury, the bleeding was very persistent. So you usually are gonna get history of recurrent bleeds after any kind of minimal trauma slash with respect to a surgery. The pattern of inheritance is autosomal recessive, so history of consanguineous marriages would also be present. Let us understand what is the fundamental defect in this case. Well, the receptor which is involved in this case again begins with B, that is 1B, and the function of this is to bind with von Willebrand factor. Von Willebrand factor is also called as tissue glue. You see, whenever any blood vessel is injured, the endothelial cells will produce von Willebrand factor and that will bind to the platelets. So this receptor that I'm highlighting here is the one which will malfunction in this case. It will not be able to bind to the tissue glue, and as a result of it, it's platelet adhesion that will falter. Well, you can see that first you have platelet adhesion, then aggregation, then the platelet will liberate thromboxane A2 to invite more platelets to join the party. So here the fundamental initial step itself is defective. As a result of it, the formation of clot will definitely be hampered. There are two main reasons why this topic is asked. One is that this is a platelet adhesion defect, and second is going to be presence of giant platelets, which could be so big that it could be falsely read by the Coulter device as a white blood cell, resulting in pseudo elevation of total leukocyte count of the patient. The question will begin by describing initially recurrent epistaxis episodes developing in this individual. Maybe he might describe a female patient who's having menorrhagia. These are all distracting points that could be given, and then he will come to the main issue, or he might begin the question by describing that the post-operative bleeding in the patient is excessive and local hemostatic measures have not been able to stem the tide. Therefore, when you're gonna do a workup of this patient, the following tests will help you know that this is Bernard-Soulier syndrome. First and foremost, the platelet count of this guy will turn out to be normal when you order a complete blood count, and therefore you're wondering what is the problem. Is it a defect of the quantity or is it a defect of quality? In this condition, it's a quality defect. The quantity is perfectly normal. As I highlighted, in the TLC of this patient would be pseudo elevated, so complete blood counts will definitely give you some idea regarding that this could be a quality defect related to the platelets. The next finding that I'm highlighting, that is large platelets or giant platelets, is good for academic purposes, but in real clinical practice, if a pathologist is not having sufficient experience with working on a peripheral slide per se, then he may not be able to identify giant platelets, so you cannot rely on a pathologist's experience for diagnosis. Since the child was having excessive bleeding or the adult was having excessive bleeding, I ordered a coagulogram. And that is when I realized that yes, my hunch was right, that there's something wrong with the platelets, because bleeding time is elevated, though platelet count is normal. Why? Because this disease is not related to quantity, it is related to the quality of the platelets, that they are not going to be able to do their basic function, that is adhesion. The prothrombin time will be perfectly normal because there is no problem with extrinsic system of clotting 5 and 7. APTT will also be normal. So the report of this person from coagulogram perspective will rather enhance your suspicion of this person having a quality defect related to platelets. The best test for diagnosis of this condition in clinical practice is to just order a PFA, that is platelet function analyzer, PFA 100 test, and you can obviously narrow down to the diagnosis. As I said, nowadays technology and artificial intelligence is replacing pathologists and radiologists likewise. So PFA 100 test is using technology to identify that there is a qualitative defect with the platelets. However, in the exam, he would like to trouble you by asking you regarding the details of Ristosine aggregation test. Well, because the reports that I'm going to explain to you of Ristosine aggregation test for Bernard-Soulier can be easily confused with that of Glanzmann thrombasthenia and vice versa. So you just need to listen to the details very carefully for Ristosine aggregation test being told to you at the moment, the interpretation, and then for Glanzmann thrombasthenia. In this case, the MCQ will always mention failure to agglutinate with ristosine. So that's the first statement that I want you to remember for questions. Well, ristosine is an antibiotic which was initially identified for diagnosis of von Willebrand disease. And even in this condition, you will notice the MCQ saying failure to agglutinate with ristosine. But when it comes to other products like ADP, products like adenosine and collagen, then the platelets are able to do their job properly. You see, if I just highlight this statement of mine that ristosine aggregation test is useful for diagnosis of this condition with the word failure being remembered by you, because you will notice that in Glanzmann thrombasthenia, I will be changing my statement. So just wait for Glanzmann thrombasthenia to come up. But this statement of mine, failure to aggregate with ristosine, is one of the important points that I want you to remember in comparison with Glanzmann thrombasthenia. And once the diagnosis of this patient has been made, best with platelet function analyzer / ristosine aggregation, we will be managing these patients on emergency basis. How would I tide over the crisis? Their own platelet quality is bad, so we will be giving platelet transfusions to these patients, though they might develop alloimmunization to these platelets also. Why? Because if you are after every surgery, you see he underwent appendectomy, then he underwent a dental extraction, then maybe a third minor surgical procedure like a hernia, because a person started having bleeding, he was giving recurrent platelet transfusion, so there is a risk of alloimmunization or antibodies developing in these patients as well. To minimize that, we will obviously like to use a leukodepleted blood. Next on the agenda is to talk about a disorder where we would be having small platelets, that is Wiskott-Aldrich syndrome. Well, the manifestations can be remembered by a mnemonic by the name of Vater, where W will stand for Wiskott, A would stand for Aldrich, not a problem. Then I just want you to remember or focus on the remaining four alphabets of Vater, that is ITER. Alphabet I would stand for immunodeficiency in this case, and the usual query can be that which antibody can be defective or which antibody levels can be reduced. So remember, it is IgM levels which are relatively lesser. In contrast, IgA is elevated, immunoglobulin E is also elevated. In fact, disorders where IgA is elevated, as I've discussed earlier, can be Henoch-Schönlein purpura and Burgess disease. Then T would stand for thrombocytopenia, and in a peripheral smear, a pathologist might comment on the fact that these are small platelets. In fact, that's one of the important carry home messages: large platelets in Bernard-Soulier, or rather giant ones in Bernard-Soulier and smaller ones in Wiskott-Aldrich. Alphabet E would stand for eczema developing in these patients, and R would stand for recurrent pyogenic infections. Most of the time he's going to give a pediatric case where all these manifestations will be given together, and some of the highlights that I have given for this topic can definitely help you in picking it up. I will now describe to you how Glanzmann thrombasthenia will present. In fact, the MCQ of Glanzmann thrombasthenia and Bernard-Soulier can notoriously look the same. So one of the important topics that are being discussed at the moment is the comparison between the two. Once you're done listening here, I want you to listen to mainly Bernard-Soulier and Glanzmann thrombasthenia again, so that you can pick up the subtle differences. You see, receptor problem, I don't anticipate that you will mess up on the receptor. That I am very sure all of you guys are highly intelligent chaps, you can easily pick it up. It is mainly the subsequent issues that I'll say that can cause a bit error of judgment. You see, the receptor that I'm talking about at the moment would be called as 2B beta 3 receptor, and the main function of this would be that it is responsible or it helps in platelet aggregation. Now, this is an autosomal recessive condition. The defect is on chromosome number 17, and he might mention information regarding marriage between cousins, that is consanguineous marriage information can be given in the question before he starts describing the manifestations, which will be an aid to diagnosis, because you know that there's something genetically wrong contributing to bleeding. Previously I was talking about genetic problems related to bleeding in the form of hemophilia, then I spoke about Bernard, and now Glanzmann thrombasthenia is there. You see, the textbook uses the following phrase to describe the problem here. He says there is both a qualitative, in this case he says there is both a qualitative as well as a quantitative deficiency of this receptor. Last time I was focusing only on the quality part. Here I'm saying two things are defective. Both the quantity part and the quality part of this particular receptor is gonna be defective in this case, and therefore the question will describe the standard presentation of excessive post-operative bleeding. Before I write that statement, he might actually try to bluff his way across and waste your first 30 seconds of the MCQ by talking about menorrhagia, maybe gingival bleeding that might make you think in terms of possibility of scurvy or hematological malignancies like AML, ALL, which can again have a gingival bleed. He might distract you by describing a person having hematochezia and you might be thinking of surgical causes, or he might say recurrent epistaxis so that you start thinking in terms of ENT causes. All these are distractors. And then he'll come to the main fact that this guy, he underwent some kind of a minor surgery and then there is an excessive post-operative bleeding occurring. Now, because the history can definitely look the same in both of the diseases, we need to be sure about which one to answer based on the workup. In this condition, also the platelet count will turn out to be normal. However, I will suspect there's something wrong with the platelets. Why? Because the coagulogram of this patient will definitely be defective. The bleeding time would still be increased. In this case, the peripheral smear will not reveal anything abnormal with respect to the size of the platelets. So earlier I was vocal about saying that size of the platelets can give you a hint regarding the diagnosis. In this case, the question will be silent or will just mention platelets appear adequate on a peripheral smear. The coagulogram will sensitize you to the fact that there is something wrong with the function of the platelets because bleeding time is elevated with a normal platelet count. Traditionally, when platelet count becomes lesser, that is when bleeding time will rise. But in this case, bleeding time is elevated and the remaining parameters are normal. So you definitely need to go in for a PFA 100. And as I highlighted, I mean, if I get a platelet function analyzer test done, I know that I have hit the jackpot and made the diagnosis. But in the question, they would once again introduce regarding the Ristosine aggregation test, and you will now notice some subtle differences. In this case, the question will say that in Ristosine aggregation test, the aggregation per se with Ristosine is normal. You see, earlier when I was teaching you regarding Bernard-Soulier, I was saying that the aggregation with Ristosine was defective, but now you can see I highlighted this failure to agglutinate with Ristosine. But when it comes to the current topic of interest, he will always say that agglutination with Ristosine will be normal. It is the second, rather the statement that is the different one, that is stimuli like ADP, adenosine, and then the last one that I taught was collagen. These are the ones which are relatively lesser. So there's a slight difference between the report for Ristosine aggregation for Glanzman and Bernard-Soulier that he would like to exploit. The management of these patients will remain standard. I will give platelet transfusions to these patients again for managing the life-threatening bleed that is occurring because his own quality of platelets is defective. As I highlighted, lots of time alloimmunization in both of these patients can occur. That's secondary to receiving the cellular components with platelet transfusion and antibodies. To prevent this alloimmunization, we should always be giving leukocyte depleted products to these patients. I have spoken about how can you achieve leukocyte depleted blood products in the blood component section, where I've talked about irradiation, where I've talked about especially use of special filters. So that would definitely do good for this person. In case he mentions that it's a non-life threatening bleed. You see, if it's gonna be life threatening, causing hypovolemia, hypovolemic shock, then I'll give platelet transfusion. But if he says non-life threatening bleed, then we can use desmopressin. Last time when I was teaching you hemophilia also, no, I talked about desmopressin being used because that helps you in increasing the activity of the platelets with the local tissues, and the function tends to improve of the platelets, and therefore the bleeding manifestations can reduce. Other products which can be used here are ECA, that is epsilon aminocaproic acid, and even topical thrombin. These are additional products which can be used to control the local bleed, like a cut on the lip, etc. Or maybe I would say this patient was undergoing a root canal, not a proper dental extraction, a root canal, and following that a bit of bleeding is occurring from the gums. So in those circumstances, these steps can be taken to help this person recover. The next topic that I'll explain to you is called as von Willebrand disease. If they mention regarding which is the most common inherited bleeding disorder, then do not answer hemophilia. The answer would be given as what I have just highlighted before you. Now, even in this MCQ, he will describe a patient having excessive postoperative bleeding. So I will try to explain to you that how, by reading the coagulogram report of the question, you would be able to identify that this is not a platelet disorder, but is mainly related to the tissue glue. Von Willebrand factor, well, what is its main function? There are two functions of von Willebrand factor, and that would help you identify the problems in the coagulogram. One, it is tissue glue, so it will help in addition of the platelet to the wall of the vessel, and therefore bleeding time will be elevated because this addition part will be defective. Second part is that it also binds to factor 8. The main function of von Willebrand factor over and above the fact that it will bind to platelet is it will bind to factor 8, and it tries to increase the half-life of factor 8. I mean, this is what is written in the textbook. The main function of von Willebrand factor is enhancing the half-life of factor 8%. Now, let us assume that a person is having deficiency of von Willebrand factor, or it is being cleared from the body, whatever. But if the tissue glue that I have just mentioned is amount wise lesser, or let me say function wise defective, then addition of the platelet will be defective, and therefore bleeding time in the question will be deranged. And because the half-life of factor 8, I was saying it is prolonging the half-life of factor 8. Now if it's not going to be there either quantity wise or quality wise, the end result is that the half-life of factor 8 will reduce. If factor 8 half-life will reduce, then activated partial thromboplastin time will also increase. Remember, I told you bleeding time is linked to platelets, and for clotting factor number 8, it is the intrinsic system, it is apetity that is to be used for evaluation. So when you read a question where both bleeding time and apetity are deranged, then it cannot be Bernard Soulier or Glanzmann, because there the problem is only with the platelets, so only bleeding time will be increased. I shall now be explaining to you regarding the three subtypes of von Willebrand disease. I would suggest you to note them down with me so that you can remember or retain them relatively better. You see, when it comes to type 1, which happens to be present in 80% of the cases, it's a problem of both the quality as well as the quantity. You can see the information that I'm writing here, that not only the function is lesser, but as such the amount of protein being produced from the endothelial cells is also lesser. When it comes to type 2, which is having 4 subtypes on its own, the main problem is only of quality. So you can see the fundamental difference, which I'll repeat once again. In type 1, it is both quantity and quality of von Willebrand factor that is deficient, but in type 2, it is only the quality issue. Whereas in the third one, von Willebrand factor is completely absent. So you can very well understand 3 MCQs coming up here. One would be mainly related to the fact that which is gonna be the most severe variety of von Willebrand disease. Your answer is gonna be type 3 variety. If he says the most common one, I've already sensitized you to that. And when it comes to type 2, they will usually ask you regarding 2N variety, which I've already explained in the earlier part, that is autosomal hemophilia. Let us also look at the differences between the subtypes that I mentioned, that is 2A, 2B, 2M and 2N. This is, however, optional for you. If you want to remember this part of the table, it's optional. The initial part of the table that I highlighted is definitely relatively more important. Well, I want to tell you that in our body, there is formation of one von Willebrand factor multipers that join with each other and help in clot formation. And then there's a product that is formed to destroy this also, because every time there's something produced in the body, there has to be something to counteract it also. So counteracting this is a function of ADAM TS13. Well, when it comes to ADAM TS13, I have actually discussed about this particular product in the literature or topic of thrombotic thrombocytopenic purpura in the kidney section as well. At the moment, I'll put it like this. Like in our Hindu mythology, we have Brahma, Vishnu, Mahesh. So Lord Brahma, he is basically the creator, and Lord Shiva is a destroyer. So you can take von Willebrand factor as Brahma, who's the creator of the clot, and Lord Shiva, the destroyer, is ADAM TS13. Now, suppose I say that the activity of the destroyer is more. If Lord Shiva will start destroying everything, everything can be destroyed. So 2A variety is characterized by increase in the cleavage activity or cleavage or destroying activity by ADAM TS13. I'll repeat that once again, guys. Like I said, a creator and a destroyer, the destroyer activity is relatively more. That is why, per se, the von Willebrand factor multipers are not being formed in adequate amount, and therefore the clot formation will definitely be hit. When it comes to 2B and 2M, not too much of difference. You just need to remember that in 2b there is a gain of function. Now remember the words, there is a gain of function. So the query of most doctors is that should cause more effective clotting. You see, when there is a gain of function, there is a spontaneous binding to platelets, so there is wastage of resources. See, what is happening in this condition is that it's not that only when injury will occur that the clot formation will occur in a faster fashion. It is a waste of resources actually occurring, because without injury also there can be a development of clot formation, and therefore because the resources are getting wasted, when the time comes, then the resources will not be available. You see, if you waste your energy in all other activities, then when it comes to energy being utilized for study, that energy will obviously be lesser. Same thing is happening here, that the body is wasting its resources, and as a result of it, when it is required, like after dental extraction, after any kind of a minor surgical procedure, when it is required that the clotting system should function, it's not going to perform. The 2M variety is a variant of 2B also. When it comes to 2N, the main problem is that of defective binding. You see, I was said that von Willebrand factor will bind to specific receptors that I mentioned as 2B, then beta 3 receptor. So here the binding problem is from the side of the von Willebrand, and the specific name that is given to 2N variety is called as autosomal hemophilia. So this particular table that I've just explained to you with example of Lord Brahma and Bhagwan Shiv, this is optional for you if you want to remember it. Otherwise, 1, 2, 3 fundamental differences should be known. Quantity plus quality, only the quality aspect, and total absence. I mean, that's how you can remember it relatively. And now let's look at the main clinical question that will come on this topic. Ultimately, our objective is to solve MCQs, no? So the MCQ can be solved like this. He will describe this 13-year-old girl. She can be a little older also. He might describe that she's having wisdom tooth, and that's causing, she's having toothache. So for that, the general physician had prescribed painkillers, but the problem is still continuing. As a result of it, now her dentist has advised dental extraction, and the parents and this girl said yes because she's fed up of taking these painkillers. Post procedure, there is excessive bleeding occurring. So initially the dentist thought that this could be a minor aberration. You definitely can have bleeding more than usual in some patients. So what the dentist suggested was that she should not talk after the procedure. You see, the packing is obviously put, but in this case, the moment the packing is removed, the bleeding is still occurring. So the dentist has advised her to drink cold water, eat ice cream, not talk much, and the bleeding should stop, but unfortunately did not. Blood is still coming in her mouth. So next time the dentist tried something different, which is he soaked some cotton in adrenaline and he did some packing so that at least adrenaline will cause vasoconstrictor effect and therefore the bleeding will stop. But in spite of all the efforts that could be done by the dentist at his clinic, the bleeding is still persisting because the moment he removed the pack, the bleeding is still very much there. So the case was referred to me. On listening to the history here, though parents may not tell about any kind of previous history or they may not have noticed as is the norm in our country, so I will have to rely not on the history, but I will have to rely on the coagulogram report. This coagulogram report is very characteristic because you will notice that prothrombin time will be normal, but bleeding time will be increased. Why? Because obviously the tissue glue is not there, so platelet is not going to be able to adhere per se. And half-life of factor 8 will also be reduced because one of the functions of von Willebrand factor is to enhance the half-life of factor 8. So even APTT will be deranged in this case. So when you get a question that talks about a girl having post-op bleeding, which could be post-dental extraction, and a coagulogram like this, you will definitely think in terms of von Willebrand disease. And what test will I do? I'll get a von Willebrand assay, which is the main way for diagnosis of this condition. Now the examiner does not want to make it easy because if he will himself write von Willebrand assay shows a suboptimal activity, the diagnosis is right in your face. So what will he write? He will again talk about the ristosine aggregation test. You see, ristosine is an antibiotic that can behave like von Willebrand factor. You see, the blood of this patient is not clotting on its own, but when you add ristosine, it will behave like von Willebrand factor. It will promote the clotting fact. So therefore, ristosine aggregation test can definitely help in diagnosis of this condition. I said this is actually an antibiotic. Looks surprising, but true. It's an antibiotic. You will say when it is added, the complete statement given in the textbook is when it is added to the plasma, which is von Willebrand factor deficient. then because it is gonna behave like a von Willebrand factor, it will help in promoting the clot development. For management of this condition, if he says what is to be done, your primary answer is once again desmopressin, that could be written as DDAVP. The main aspect I want you to remember for this topic is the coagulogram report and post-procedure bleeding that would help you identify, because this report is different from what I described for Bernard-Soulier and Glanzmann thrombasthenia. In this question, if he wants to make the question longer and give you hints, subtle ones, then he can definitely talk about this girl. She's 13 years of age, so maybe her menstrual cycle has started. So menorrhagia, though the parents are or the mother is thinking that the menorrhagia component is because initially the cycles can be relatively heavy also. Then the bruisability of this girl will also be on the higher side. Like the mother might tell you in retrospective, like when this girl, she had fight with her brother and the brother hit her. When siblings keep on fighting, so she might say that there is a lot of bruises that can develop on her body. So I mean, though that kind of history may or may not be given, but coagulogram report will definitely help you in identifying this condition primarily. I will now teach you about a very peculiar aspect. You see, I'm describing a patient of valvular aortic stenosis. You will be wondering, why am I discussing a cardiac case here? You see, this patient who is having valvular aortic stenosis, he might have undergone some procedure also, like a valve repair, or he might have undergone maybe a valve replacement also. I just want to say at this particular point of time that the shear stress that is produced due to the opening and closure, you see, there's a lot of turbulence in this condition. Aortic valve is a high pressure area. When blood will go out of the aortic valve at a high pressure area, there might be shear stress generated, and this shear stress might actually even act on the RBCs. No, I'm not teaching macroangiopathic hemolytic anemia. Macroangiopathic hemolytic anemia, I've already told you that prostatic valves can result in development of macroangiopathic hemolytic anemia. This time I did not say the word prostatic valves. I said a person is having valvular aortic stenosis, its original heart valve, let me say, present at the moment, not even undergone surgery. He could have undergone surgery, not undergone surgery, because valvular aortic stenosis, it's difficult to correct per se, because it causes a very severe defect. So the shear stress on RBCs could be present in spite of the surgery component. The bottom line is that this shear stress on the RBCs due to turbulence can also be associated with a decrease in the activity. It might look a little surprising to you, but listen to this with an open mind. Studies have shown that the shear stress that is created might even contribute to decrease in von Willebrand factor activity. And because von Willebrand factor activity is lesser, therefore in these patients tendency to bleed can be present. That is in the form of GI bleeding. It could be maybe hematochezia developing in this guy. You see, surprisingly, I'm teaching you a case of cardiology, a aortic stenosis patient who has or not undergone surgery, who is having shearing stress on the red blood cells. Okay. And along with that, the von Willebrand factor activity is also reduced, which is causing bleeding tendency. This is a rare, actually a syndrome where Harrison has mentioned this in actually italics because of the rareness of the disease per se. This is called as Hedges syndrome. So I just want you to remember the terminology here. Combination of aortic stenosis with GI bleed is what you call as Hedges syndrome. And that's just an additional aspect that I want you to remember, though my main focus was you to remember the clinical domain or clinical presentation of a hemophilia patient versus von Willebrand versus Bernard-Soulier versus a Glanzmann thrombasthenia. And in the end, I'll compare various coagulograms before you so that this becomes a permanent memory for you. So you can quickly grab a pen here and start making a table with me, because though I know it's given in the notes, but I would like you to listen to me and note down simultaneously so that it makes more sense to you. The first entry that you have to make is that of dengue hemorrhagic fever, where platelets will be lesser. Therefore, bleeding time will be increased. But dengue will not say anything to factor 5, factor 7. Therefore, prothrombin time will be normal. Dengue will not be affecting the activity of the other system, that is APTT. So intrinsic system is unaffected. So therefore, the report will only say a deranged bleeding time. But when I was describing a case of hemophilia before you, then in factor 8 deficiency, APTT was deranged, 5 and 7 are normal, platelets are also normal in hemophilia A. So as such, in the second report that I've written before you, the derangement is per se only for activated partial thromboplastin time. In contrast, when you take up a case of chronic liver disease, because factor 7 is the one having the shortest half-life. Therefore, prothrombin time will be deranged, but the remaining parameters will be normal. When it comes to consumptive coagulopathy, one of the important causes of DIC is sepsis, and after sepsis, it's gonna be obstetric causes. Like one of the obstetric causes can be abruptio placentae, or it could be intrauterine death. And therefore, in DIC, because platelets will also be consumed, factor 5, 7 will also be consumed, 8 will also be consumed. So, because all are getting deranged, that is why we are gonna use, or rather, I would call this one of the more torrential forms of bleed that will be occurring in a person will occur in DIC patient, because everything is getting consumed. When it comes to thrombotic thrombocytopenic purpura, though it's discussed in the kidney section, TTP, again, bleeding time can be deranged, though PT and APTT can be normal to slightly deranged. In fact, for TTP, I would like you to specially listen to the discussion in the kidney section where I've justified the coagulogram report. And lastly, I spoke about von Willebrand disease. The problem was platelet addition is defective. The half-life of factor 8 is also gonna be hampered in this case. So therefore, you would be having a deranged bleeding time and an increased APTT. I deliberately went faster here. I deliberately mentioned these parameters because this is not multiple MCQs. This could actually be a single question where he can incorporate increase, decrease of various parameters and can bog you down with the data. I want you to be very thorough with this entire table that I made before you. And one quick hack that I can mention is that prothrombin time is always deranged in chronic liver disease, but prothrombin time is always normal in von Willebrand disease. I repeat that, though obviously you need to practice the entire table. Prothrombin time is always deranged in chronic liver disease. All the scores of the liver that I've explained to you, there is a deranged prothrombin time, but PT is always normal in von Willebrand disease. Well, lots of time you might even be having confusion between DIC and TTP, because this is a common query that I get from right in the end, because students say, sir, you said everything deranged for DIC, then you said everything can be deranged in TTP also. Yeah, possible. In those cases, how will you differentiate? Well, the differentiation will be based on serum fibrinogen values. Serum fibrinogen values will be substantially reduced in cases of disseminated intravascular coagulation, but will be given normal in thrombotic thrombocytopenic purpura, as the name suggests, thrombocytopenic purpura. So this condition TTP can be associated with development of stroke also. TTP per se has been discussed in the kidney section, so you can go through it. There's a one full lecture on that. But if you can just practice this table that I've highlighted, you would be definitely in a better position to evaluate and answer questions related to bleeding per se. And over and above this, I would like to finish this discussion by basically mentioning that if a person is having bleeding in the emergency or right before surgery, then we can do a test that can actually be performed in emergency and can measure the entire clotting system. The name of the test is thromboelastography. This was itself a question saying that which test, because in other tests like coagulogram, PT, APTT, I was talking about various components being tested like extrinsic system, intrinsic system. But if you have to test the entire clotting system in one go in a emergency scenario, that could be mostly in the casualty, mostly pre-operatively. In those circumstances, the test that you will answer will be given as TEG, that is thromboelastography. So these are the details that I want you to listen for this topic, practice and keep learning, guys. And you're doing great. I assure you the fact that the moment you keep on learning one new topic every day, you are bang on track for having a great career. Thank you so much for hearing me out.